Okay, and welcome to the Davie's Use Case webinar being presented by California Correctional Healthcare Services on automated clinical risk classification system. This is the Davie's award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety here at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar, Dr. John Dunlap and Michael Selby. Dr. Dunlap and Michael, you can begin when you're ready. And thank you for joining us today.
Hello, and welcome to California Correctional Healthcare Services HIMSS Davies Award presentation on Automated Clinical Risk Classification System. My name is John Dunlap. I'm Deputy Medical Executive in the Quality Management Unit, and my co-presenter is...
Hi, I'm Michael Selby. I'm a Health Program Manager 3 over the Performance Evaluation Team within the Quality Management section.
So thank you for HIMSS for the opportunity to present to its members and share our exciting healthcare informatics work that CCHCS is conducting. And today what we're going to be talking about is the clinical risk classification system. So we're going to review the problem, talk about the design and implementation, how IT solution was utilized, and then the value derived from this IT venture. So a little bit about our local problem. California Correctional Prison System is large and complex. It's made up of 35 different adult facilities housing roughly 125,000 adult offenders across the state of California. 96% of our population is male and 4% is female. We do over 600 intakes every week from 52 different counties within California, and we have roughly the same number of people exiting every week as well. Nearly 1/4 of our population is over the age of 50. In general terms, the prison population is considered to be 10 years older than non-incarcerated populations due to socioeconomic factors, as well as great prevalence of substance abuse, significant mental illness, and other factors. So, like other healthcare systems, we're faced with the problem of efficiently and effectively delivering services over long periods of time. And so we also are facing an aging population and a population with more disease burden than observed in the free community. So over the years, we have made significant strides to ensure that we are improving our effectiveness in delivering a full scope of healthcare services to the adult offender population. One of the most important steps that we took in this endeavor was to create our medical classification system. This classification system was intended to ensure patients were connected to the right resources, but as many great ideas start, the clinical risk classification had to go through some improvements to become what it is today. So our problem statement was that our high-risk population are not consistently and accurately identified and placed throughout their incarceration to receive the right level of resources. So what this presentation is sort of demonstrating is roughly a Pareto's principle, where higher risk people are driving more resources, and the proportion of the population is also should be driven to specific institutions. So the intermediate institutions, which there are 10 or 11 in our system, and the rest of our what we call basic institutions, really is a way for us to identify which institutions have greater resources in terms of staffing ratios, as well as closer proximity to higher level of care in the free community. So going back in time, just as a little history, the evolution of our medical classification system. In 2006, when the receivership began, this is what we were started with, which is our custodial colleagues had little or no consideration for healthcare factors when they looked at housing placement for the incarcerated population. Partly because of this, the receivership went into place as we were found to be in violation of the 8th Amendment of the United States Constitution, cruel and unusual punishment. The 3 years after we went into receivership, the first version of the medical classification system was introduced. It was basically broadly defined risk classifications of high, medium, and low, and it was open to a lot of interpretations. So it was a step in the right direction, with healthcare factors now being considered. However, they were often inaccurately done, and then once that was done, it was infrequently updated. So really, one of the other pieces of this is that it's a patient-dependent paper process, and we had to get that paper to custody. So over time, we improved this. 2012, we electrified this form, and the communication to custody improved, but again, it was still a person-dependent process, and the rules were still not standardly applied. There were inaccuracies persisted, and still was not updated timely. So come 2013, we introduced the automated clinical risk classification. Prior to our new solution, again, just to review, providers conducted the review in the patient records to determine the risk. Providers manually entered risk into the e-form. The e-form transmitted information to SOMS, which is the custodial database, strategic vendor management system. And then custody used that healthcare factors to inform appropriate placement of the inmates. When a clinical status changed, however, the providers had to manually update that e-form. They had to remember to do that, which was routinely shown that through audits that there were discrepancies between the reported risk and the actual risk of the patient. So where did we start? Only 62% of the high-risk patients were properly placed based off of the audits that we did. So we looked at some of the baseline data for hospitalization readmissions rates, comparing our high risk to our total population. So we saw a slightly higher increase in readmission rates to the high risk population, and potentially avoidable hospitalizations per 1,000 rate. It was significantly higher for our high risk patient versus the total population. So again, what we really wanted to do was try to get these people to the right places so we could improve the care to these patients. So expected project outcomes, we're looking to clinically increase appropriate placement of the high-risk patients, which would lead to a reduction in preventable morbidity and mortality. And we also wanted to leverage available data and IT to administratively automate complicated clinical rules so that they were standardly applied. We wanted to provide timely and actionable information to our custodial colleagues as to when patients' clinical risk changed, that they would be notified promptly and reliably. And then also we wanted to provide real-time performance reports to show whether or not that we were moving patients that were identified as high risk to intermediate institutions. So we're going to go into design and implementation now. So when we were first challenged this by our leadership to develop this project, we looked at the available commercial off-the-shelf products, not because we could purchase one, but we wanted to utilize what had already put out there by the experts. The reasons why we could not go with the commercial off-the-shelf product was because one, it cost money and the state did not want to pay us or pay for such an application. But primarily, we found that it was not going to be useful because our providers, who are salaried employees of the state, don't bill for their services. So we did not have the claims data for primary care services. And then we also had unique requirements for the correctional setting that none of the commercial off-the-shelf products had available. So we did look internal, and we had the existing resources available to us that we felt would allow us to move forward. So we had the e-form application, which was our conduit to reporting to custody. We had the healthcare data warehouse, which is we'll talk about more in the further on in this presentation. And then we had the in-house talent of clinical and technical people working side by side to develop this. Developing the IT workflow. So, okay, what we basically did is we mashed up a bunch of different information on our patients, and then we automated this through automatic jobs that run on a regular basis. So every 24 hours, and sometimes even more frequently is every 12 hours. We would then route that through the e-form application directly to custody, and then that would notify them of the change. So that's the high-level workflow of what we designed. But how did we engage the people to do this? So we wanted to make sure that this would be useful to the staff involved. So we had to go through and look at all the existing rules, and then we needed to do some modification to those rules. We defined the risk levels and the available sources of the data. Then we went to the defined high-risk factors, so looking at chronic diseases, the degree of control, that would vary. So a patient may have diabetes, but not all diabetics would be high risk, but those who were diabetic and had complications would be considered high risk. Those that had maybe a bad A1C would be medium risk, and those that were well controlled would be low risk. We also looked at age, number of medications, frequency of hospitalizations, and emergency room encounters. Then we defined the rules for each of the factors. So again, we defined advanced age as 65, which would be a high-risk factor. We also looked at people who had 4 or more chronic conditions, or one specific problem-prone condition would be high risk. Then we went through and defined the data elements and the data sources for these factors. Excuse me. So basically, we looked at available data resources or information sources, such as our problem lists, custodial demographic information from SOMS, our pharmacy and diagnostic information systems, and claims data. We created decision support for end users so they would understand the rules of the clinical risk and have common nomenclature for risk levels. Here you see we have decision support materials that identify high risk as 1 and 2. From a clinical standpoint, this wasn't relevant. However, our custody colleagues expressed concern about potentially having to move approximately 11,000 patients that were identified as high risk. So we sort of created an arbitrary distinction to identify the high risk 1 category as the highest priority for movement to an intermediate institution, essentially that they had more than one high risk factor. The other piece that we're showing here on this new slide is that we needed to share with end users how we identified patients with particular conditions that were going to be included into our clinical risk classification system. So in the screenshot, you see our condition specifications for diabetes. And what this tool does is it outlines the rules for inclusion in that condition and how a patient's risk level would be stratified by the degree of control for that condition. So in this instance, a diabetic patient could be classified as low, medium, or high, depending on the degree of control. We have other conditions for patients, such as end-stage liver disease and HIV, that currently are identified as high risk only. All right, so really what the secret in our sauce is this partnering of our business owners with the IT developers. So basically the clinical SMEs working with our programmers to create the utility of these tools in a rapid and efficient way. Michael will talk a little bit more about this in detail further on. Got to pass it over to Michael now.
All right. So once we had risk level and patient location information, we could build a report to help custody staff move inmates to the appropriate institution based on their medical risk level. So we built a SQL Server reporting services tool that allowed custody staff to see just that. SQL Server Reporting Services, or SSRS, is a Microsoft commercial off-the-shelf product that staff can use to build these front-end interactive paginated reports. This product, SQL Server Reporting Services, integrates very well with a Microsoft SQL Server backend, but can also be used with and connected to other database applications or other data sets. So this particular view of the report allowed executives at headquarters or at institutions view at a glance, essentially, how the process of moving these high-risk patients from the basic institutions where we're trying to move them out of and get them into intermediate institutions. So they could see on the left-hand side what their overall population was and what their population was across the low, medium, and high risk levels. And then on the right-hand side, they can see what percentage of their current population is high risk. And we've color-coded that, so less than 5%, which is our goal, is in green. More than 5%, as you see here, is in yellow. And then if it was really bad, which I believe it was initially, there was some red color coding. So you can see at a glance really quickly how well the process of moving these high-risk patients to basic institutions is going. This next view is essentially a drill-down view of the first report, and it shows high-risk patients at the basic institutions. And so these are the specific patients that staff should be looking at to see which are appropriate to move out of the current institution into an intermediate institution. And then this last view is an overall summary showing month by month what our progress was in terms of moving these patients. And so we did a trend, and then we did basically an expected versus actual to see what the progress was. So it shows our progress towards our goal and calculated how many patients needed to be moved per month and how many were actually moved per month. So once we automated the process to calculate a patient's medical risk level, we were able to build tools to not only give this information to custody staff to help with placement, but also to inform clinical staff to help with clinic operations. So we created this master patient registry, which lists all patients at a particular institution, shows their medical risk level and the medical conditions they had to help with patient care and coordination. Later, we also built a patient summary report. You can access this report from many of our tools, including all of our registries, by just clicking on a patient's identification number. And then this patient-specific report comes up, which combines data from 20 plus different data systems on a patient into a one-page summary view of all of a patient's medical factors, including their risk level. Later in the process, we also greatly increased the transparency of our automated clinical risk classification system by creating the patient risk profile report. So clicking on a patient's risk level in any of our reports will bring up this report, and it displays each patient's medical conditions and all the data points we use to identify that condition. So in this particular example, we've identified this patient as having end-stage liver disease, diabetes, hepatitis C, unspecified hepatitis, hypertension, and dyslipidemia. And they can see what are the factors that we have automatically captured in order to identify each of those conditions. Now, since this was an important goal for our organization, it was put on the statewide performance improvement plan, and we put a measure looking at our compliance with that goal on the dashboard. So the very top dashboard measure on the pop-out you're seeing is titled Appropriate Placement of High-Risk Patients, and that is the measure. So that particular measure calculates the percentage of high-risk patients who are currently housed at an intermediate institution. So this was the score that Dr. Dunlap mentioned was in the 60% when we first started looking at this process. All right, so what happened when this process was implemented? So now the provider no longer needs to conduct a chart review to determine a patient's clinical risk. Instead, they just do their job of seeing and caring for the patient, and that feeds information into our SQL Server data warehouse, which then updates the risk if any risk factor changes. They also don't have to enter a risk level into the eForm anymore. Now that field is automatically calculated in our data warehouse by our automated process and dithered out on the form. The eForm does, the automatically generated risk level does still get automatically fed from the eForm to SOMS, the custody application, which is then part of the decision of where to house the patient. And finally, the provider doesn't need to remember to update a patient's risk level when their medical conditions change. Instead, the automated algorithms picked up the change factor and automatically update the patient's risk on the form. All right. Now the patient's medical risk level is automatically updated whenever we detect additional factors relevant to their risk level. An automated SQL job runs twice a day to pull in all the relevant information, and we recalculate everyone's risk level twice a day. A changed risk level, if they go from high to medium or medium to low or the other way, that would place an alert on that patient in the custody application that the risk level has changed. Then the correctional counselor who's in charge of patient placement reviews patients whose medical risk level has changed and is flagged, as well as patients identified through the custody registry, which we saw earlier, as being candidates for being moved. They then use the medical risk level, along with custody information such as sentence length, offense committed, and security level, to determine the appropriate housing for that patient. Then finally, once they've determined the appropriate location for that patient, custody staff will move that patient to the new location. So what enables all this to happen? So we first had to create the infrastructure that allows us to build all these tools, while we also worked with the end users to determine what the output and the tools should look like. So for the infrastructure, we worked with information technology staff within our organization to develop automatic data feeds from the data sources we needed. We started out with really just 4 data sources that we found we were able to do a lot with. So those were diagnoses from paid specialty claims, pharmacy data from prescriptions and dispenses, lab result data, and patient demographic information such as patient location and age. So we're able to get automated feeds of these data sources into one centralized server running Microsoft SQL Server, which was the beginning of our data warehouse. Again, we found we could do a lot with just those 4 data sources initially. So we then take that raw data from the different information systems used by clinical and custody staff in the field and transform it into structured, meaningful information. Bringing these disparate data systems together in one place is what enables us to build all the cool tools we have developed. So in this case, we connected these data systems together at the patient level to determine which medical conditions a patient likely had based on the rules created by our clinicians. Then, based on the medical conditions a patient has, we calculate a patient's overall medical risk level of low, medium, high risk 1, or high risk 2. Then we take that risk level and feed it into various healthcare tools, such as the e-form, the master patient registry, the patient summary, and the patient risk profile. It's also fed into the custody registry for patient placement purposes, and is used to calculate the appropriate placement of high-risk patients' dashboard measure. So these tools all pull data from our backend SQL Server databases using Microsoft's SQL Server Reporting Services project that integrates very well with Microsoft's SQL Server. So let's take a little closer look at what our SQL Server data warehouse looks like. So again, on the left-hand side, we have a number of automated feeds coming from our different healthcare systems, coming from our custody applications. And we also have a number of legacy applications we also pull data from. And then we pull information from other places such as SharePoint lists or Excel files that we may upload. And then there are a number of jobs that run at regular intervals. These are called ETL, or extract, transform, load jobs, which then take that raw, unstructured data from the different data systems and turn it into more usable, structured information. We're then able to take that more structured information and do a variety of things with it, including different ad hoc analyses or data mining. And then that's usually for questions for our executives. We're able to answer a variety of questions pretty quickly with all the data we have at our disposal. But then, of course, we also produce the automated reports that you guys saw earlier in the form of the custody registry or the master registry or the patient summary or the dashboard. So that is our data warehouse. So how do you get staff to actually use these tools after they're built? So change management always needs to involve executive leadership at some point in the process. In this case, it started from the top with our leaders talking about the changes coming to the systems and the processes and letting them know what was expected. There was constant communication from the top. So there's a big memo that came out directing staff on the new process and the new tools and the new policies around this changed process of identifying patients' clinical risk level and then moving the patients to the correct location. This particular project was also somewhat different than most of our other ones in that custody staff were involved in the process. Most of our projects are healthcare only, but since this one involved custody staff, we needed to understand the custody organizational structure that controlled patient placement. Then we worked on communicating directly with the staff who would be involved with the change process. We did a lot of training, so especially of custody staff on this new process, and a custody liaison was used to facilitate that. Obviously, policies and procedures had to be totally rewritten based on the new process. Since we went away from letting providers specify a medical risk level to an automated clinical risk classification system, we had to build an override process in order to handle any exceptions to our automated rules. And then we produced decision support materials to help people understand how the tools worked and how to best use them within their normal workflow. And then we looked at regularly with the dashboard measure how well this process was going after it was implemented. Now, in general, our whole goal in the quality management program is to make it easy to do the right thing. And so towards that goal, we attempt to make our tools easy to use and easy to access. And so in this case, in order to facilitate access, we added a link to our custody tools from the custody intranet site. So normally our other tools are all hosted off of our healthcare intranet site. But in order to go to where our users were, in this case custody staff, we added a link to their particular site to encourage use of this new report. All right, back to you, Dr. Dunlap.
Great. Thank you, Mike. Okay, So how did it turn out for us? We're going to look at this. So we implemented this in June of 2013, and again, we had about 62% of our high-risk population appropriately placed with the new standardized rules for risk classification. And over the next 3 years, we basically did see an increase of about 20%, 18% placement in that 3-year time period. And then subsequent to that 3-year measurement interval, we were able to sustain the 80% placement. And now you may recall Michael's slide where we showed the goal was, I think, 90%. So we never achieved our goal. And we'll talk about that a little bit as a lesson learned. So there is one little dip that we just wanted to call out here at the end of end of 2015, beginning of 2016, and this is where we did a code conversion to ICD-10 from ICD-9. We also made some slight modifications to our high-risk rules, so we actually saw an increase in the overall high-risk population, but also a decrease in our performance, but we recouped pretty quickly from there. So what about our clinical outcomes? We did show a slightly increased reduction in our high-risk hospital readmission rate by 4% as compared to our overall population that showed a 2% reduction over the measurement period. But more impressively, we did see a significant reduction in the potentially avoidable hospitalizations per 1,000 rate, where we dropped from 70.9 to 43.5 in our high-risk population as compared to our hospitalization for potentially avoidable patients for the total population from 10.2 to 8.9. So what was the cost of all of this for us to do? So just a couple things I want to call out first, which is the fixed costs associated with the healthcare data warehouse and all its applications are sort of for all of our tools. So it's not specific just to this application, the clinical risk classification. So we're putting it in here, but this cost actually is spread across all of our tools, of which we have probably close to 70 different tools, including our dashboard. So our IT costs for storage and software were, a little over $500,000. Our contract for our database administrator and developer, $125,000 a year. So roughly, we're estimating our fixed costs of about $650,000. The development from the labor costs, again, were just about $150,000 for the clinical SME and the QM programmer's time. And then our maintenance and operations costs, roughly about $30,000 a year. So what did we save by doing this? So again, this is sort of a swag of our math, which I'll explain, but we see now about 230 risk classification changes per day. And if we estimated that a clinician took about 5 minutes to review the patient's chart to determine their clinical risk, we figure that would be about 12 forms or risk assessments per hour. And at the time that we implemented this, the physician classification salary roughly estimated about $100 per hour. So we calculate that to be about $1,900 is saved per day. So over the 3 years, it was over $2 million. The benefit, though, is that this clinical risk classification system just keeps saving us money over time. So comparing ourselves to the outside world, hard for us to do, but in terms of the models that we saw when we talked about looking at the commercial off-the-shelf products, a lot of the models used the same variables that we did in terms of age, gender, drugs, diagnoses. Also, some used disability and functional status as well as procedures, but few or none that we saw were using provider specialty, claims data, and or lab values. So these are things that the check marks here are the things that go into our clinical risk, and for better or for worse, I can't say, but our clinical risk uses more factors than others that we could find. So user feedback, as Michael referenced before, we had to build in a way for the clinicians to be able to object or contest some of the automated clinical risk findings. There's always exceptions to rules from a clinical standpoint, as well as sometimes there's just bad data, as you all probably are aware. So basically we created a pathway in which the primary care clinician had to basically get his supervisor and his supervisor's supervisor to agree with any risk level change that they identified. And so basically, if we had 3 providers with a consensus of yes, the risk level's incorrect, we would make that change. The other piece was a lot of clinicians were asking, why was it that this patient has this high risk level or that? So we created a second tool, which we call the patient risk profile, that would identify what data points were going in to inform the clinical risk. So on the left-hand side, you see here basically a patient who is identified with end-stage liver disease is automatically given a high-risk level. But had he had just diabetes, HCV, and unspecified hepatitis, he might have only been medium risk. Except now that you also go here to the center, you see he's also over the age of 65. He's 71 years old, and he also has 1 risk factor. So, in fact, he has 2 reasons for being high risk, and then where we're pulling the data from on these. So again, the hypertension is highlighted over here on the left, CVD, HTN. And so the condition specs down below will tell you why he's being flagged for that. So you see he's got a prescription for lisinopril, and he also has diagnostic data in the problem list. So lessons learned. I think the overall arching lesson that we had as an organization is that data is an asset and should be managed and leveraged to the benefit of the organization. So not just for patient benefit, but also for cost savings and efficiencies. Risk classifications should not be a static thing, so we needed a way again to resolve disputes between clinicians and our standardized logic. And then basically what we found is that through feedback from end users is that sometimes we undercalled or overcalled conditions, so we needed to have a reevaluation periodically of our rule set. And that's what you saw again when we applied ICD-10 code. We also did some modifications to the rules. With the right IT infrastructure, our healthcare organization can start to do large-scale improvement efforts. Unique to us is that a large majority of our population is in quote-unquote outpatient, though we do sort of resemble some inpatient practices, particularly around medication administrations. So we are a unique beast as a healthcare entity, and so we have to sort of create our own tools that suit our business needs. Time frame for our goals. So this is what I referenced earlier. We probably were a little ambitious or overly ambitious in our goal setting. We think that we were focused that how hard could it be to move 10,000 high-risk patients. Well, as Michael alluded to, healthcare factors are just one set of factors that go into placement. So the custody colleagues of ours have additional factors that they have to, and sometimes those factors compete. So if you have somebody who is has to go to a high security institution and has identified enemies because of gang affiliations, they may have to be only placed at one or two institutions, and if those exclusive institutions cannot provide the appropriate resources for healthcare, then the decision has to be what takes priority. And sometimes healthcare wins out, sometimes not, but there's always that constant tension between healthcare and custody factors when there is conflict. So communication between the partners is an ongoing thing. And then change management strategy may need to be revisited. So again, I think because we are a healthcare entity, and we were working primarily on a tool that was to inform our custodial colleagues, we probably should have focused and engaged more with our custody stakeholders and really tried to demonstrate the performance to the custodial leadership, as opposed to having the focus be on our healthcare dashboard, in which our custody people probably are not paying attention to as closely. So that's it. Thank you again for joining Michael and I for this presentation.
Okay, we would like to thank our speakers from the California Correctional Health Care Services for joining us today and speaking on their Davie's use case. We would like to remind our listeners where to go find this Davie's use case and other important information on how to apply for Davie's. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That is hims.org/Davies. Once again, we would like to thank our speakers today and thank you for listening.